I'd like to hand over to Naoko, our Assistant Director General for a Healthier Population and a staunch supporter of this series of webinars. Naoko.
Thank you, HM. Good morning, good afternoon, good evening, everybody. I would like to welcome everyone to this webinar on the social determinant health, equity, and COVID-19. Thank you very much for joining us. The devastating impact of COVID-19 is apparent. We are seeing the incidence of new COVID-19 cases continue to accelerate and the number of deaths continue to climb. Among those affected, communities and people living and working in vulnerable conditions have experienced a disproportionate impact of the pandemic. The pandemic and the containment responses have magnified the inequity in the social determinant of health that existed before. This is not only for the short-term impact, but long-standing inequity in health are needed to be addressed that pervade society at large. In the face of this inequity, there are many efforts to incorporate health equity into their response by government, community, civil society organization, and others. The work of ensuring equity principle manifesto in building back better policies will be critical to lead the way to promote health equity. At the WHO, we will commit to continue to advocate evidence-based policy and support countries to ensure that the world stay true to equity as a core value. There is a challenging task ahead of us, but we can learn from each other. During this webinar, we will hear from our guest speakers from Canada, South Africa, and France, who will highlight how the social determinants of health are being addressed in the COVID-19 pandemic to support health equity. A warm welcome to our three guest presenters. I would like now to hand over to Sir Michael Marmot to provide an opening remarks before we hear a summary of the evidence from an ongoing WHO systematic review on impacts of the COVID-19 pandemic and health inequity. Thank you again, and I would like to hand over to you, Michael Marmot Sensei. Over to you.
Thank you, Naoko. And echoing what Naoko said, I've been saying since the beginning of the pandemic that it exposes the underlying inequalities in society and amplifies them. We're all transfixed by the pandemic and the steps we need to take to control it. But that does not mean we should forget everything else. In fact, Dr. Tedros, the Director General, tweeted, I think yesterday, the importance of continuing to focus on the enduring inequalities between countries and within countries that amplify the effects of the pandemic and continue with all the other problems of health inequity in the world. And it's even more important because although it doesn't feel like it at the moment, the pandemic will pass and we will come out of it. And the question is, what kind of societies do we want to build as we come out? And the social determinants of health and health equity must be at the heart of our thinking as we come out of the pandemic and think about building healthier societies. So this series of seminars is absolutely vital in drawing attention to the underlying inequalities in society on which we must focus while we attempt to control the pandemic. Thank you. Etienne.
Thanks very much, Naoko, and thanks very much, Michael, for these introductory remarks. As you said, Michael, I mean, this is vital because we want to really generate a dialogue on this issue. And of course, out of this dialogue, hope there will be action. So we'll have three more parts to this webinar. The first one will be a global overview of what we know so far about COVID-19 and inequities. And then we'll have three country examples, as Naoko said. Before we continue, and then the third part will be a question and answer, which I hope will lead to some concrete ways forward. Before we continue, though, I'd like to ask or let you know that we are going to record this webinar and this discussion, mainly to make it available to those who cannot join us here right now, but will be looking at it in the days and weeks to come. So I hope you're okay with that, but if you're not, please let us know in the chat, and we'll find a solution. Well, now I'd like to turn to our next speaker, which is Nicole Valentine, which is the acting unit head for the team in my department working on equity and health. Over to you, Nicole. You're on mute. You're on mute, Nicole.
Thank you, Etienne. I'm just going to share my screen. Bear with me. Can you all see the presentation? Okay, thank you. This presentation provides highlights from an ongoing evidence review of the extent, scope, and impacts of the COVID-19 pandemic on health inequities. The review is being conducted by WHO with the Institute of Health Equity at the University College London. The review aims to address these three questions. Which social determinants of health are impacting inequities in infection, severity, and mortality? Which population groups are at higher risk? And how is the COVID-19 pandemic affecting other health outcomes through the social determinants of health? From this review, we are seeing that social determinants are incredibly important for COVID-19. A systematic review has found that of the 46 studies reviewed, 44 showed that socioeconomically disadvantaged populations are more negatively impacted through a range of different social determinants of health, such that they have higher COVID-19 infection rates, worse COVID-19 severity, lack of access to treatment, and higher COVID-19 mortality rates. The extent of inequities in infection and mortality attributed to the social determinants of health in the literature is quite large. For example, in data shown for COVID-19 death rates by area deprivation quintile in England, death rates in the most deprived area quintile, shown in the graph by the topmost two bars, are roughly double the rates in the least deprived area quintiles for both males and females, as represented by the bottommost bars, which are the least deprived quintiles. The scope of the social determinants of health that are exacerbating health inequities in COVID-19 outcomes are quite broad and include, across the different studies we've reviewed, to date about 200 reports, the following: poverty and reliance on daily wages or the informal economy, weak social assistance programs, deprived housing, deprived public areas, and poor services, in particular through in housing, crowding, and through poor sanitation and hygiene facilities, poor health coverage and poor access to healthcare, poor and inappropriate information, and living and working conditions requiring public transport or higher mobility. Across all of these is, of course, the gender inequity dimension. Multiple of these social determinants are concentrating in particular population groups and settings, increasing their infection and mortality rates from COVID-19. In addition to poorer populations, the intersections of social determinants of health have been studied most extensively in the literature for the following populations and settings: essential workers, public-facing occupations, healthcare and social sector workforce, ethnic minorities, in institutional settings, homeless populations, for migrants, refugees, and internally displaced people, and populations with pre-existing NCDs and other health conditions making them susceptible to COVID. Increasingly, data is available for populations, though limited, defined by occupation. Specific data from France shows how infection rates are related to intersections of gender and the status of your position at work. Higher infection rates were found for women and are partly attributed in the study to the lower average status they have at their work. The French data shown in the table finds also that infection rates from work are higher overall, and they show a social gradient. They are higher for employees, shown at the bottom at 34%, compared with mid-level workers, compared with managers. Very highly visible in the literature is the evidence on inequities in COVID-19 for ethnic minorities. From a systematic review, a majority of 34 studies from the US and the UK showed increased risk of negative clinical outcomes for infection, hospitalization, and mortality for ethnic minority groups. While this wraps up key findings from the studies of COVID-19 inequities, we are also just starting to review the negative impacts on other health outcomes linked to the social determinants of health. A few key points on these following slides are presented. For income, social protection, and basic services, 153 out of 200 countries have needed to offer cash transfers and 94 out of 200 financial obligation support. From financial insecurity, health impacts being documented are increased stress and deteriorated mental health, an increase in violence and substance abuse, and deferral of health care that is needed. COVID-19 infections are rising, and there is a fear that these might outpace the social protection needs. Related to education and child development, education facilities were reported as having closed in over 200 countries, affecting 86% of children in primary education in countries with low development. Health impacts reported have been the worsening of nutrition in children, increased violence against children at home, and an increase in teenage pregnancies. Related to employment and working conditions, a study across 17 developing countries showed that 70% of the lowest income household had lost one position of work. Health impacts reported for these marginalized workers and unemployed as a result of COVID include lower well-being scores, higher levels of distress. Fears are that the COVID-19 pressures will further undermine employment conditions. In relation to food security, studies across the globe are reporting nutrition concerns. Rises in food prices, increases in food insecurity, decreases in fruit and veg consumption, and increases in hunger, and uptake of nutrition supplementation programs where these are available have been reported. COVID-19 is also predicted to double the number of people on the brink of starvation. For gender equity, women are experiencing increasing levels of violence and exploitation. There has also been reported a decrease in the use of sexual and reproductive health services, and there is again a fear that COVID-19 may reverse gains in gender equality. As regards social inclusion, attacks against refugees and migrants have been reported. There's, on the positive side, an increase in some uses of health services provided to homeless populations who've been housed following the epidemic. There is, however, a fear that COVID-19 may entrench restrictions on international and internal movement of people, fueling racism and related social inequities. So in conclusion, we can say from the review that we've done that the COVID-19 pandemic is indeed highlighting the importance of the social determinants of health. We can also say that indeed it is impacting more heavily the already socially disadvantaged groups and exacerbating health inequities from what we can see. As countries respond to and emerge from the pandemic, it is therefore vital to review policies for their impacts on health equity at the heart of the immediate response, but also to implement mitigation measures to address the inequitable impacts as part of the longer-term approach to recovery. Thank you.
Thanks very much, Nicole, for these preliminary results. I mean, this pandemic is only less than 1 year old, really, and there is already overwhelming evidence of the inequities it contributes to and exacerbates. And this is just the beginning, I'm sure, and we will continue working on compiling some of that evidence and hopefully quickly disseminate it through a number of policy briefs. But thanks very much for this initial overview. We'll now move to our three panelists to get examples from what's happening in different countries, Canada, South Africa, and France. And I'd like to start with Kwame Mackenzie, who is the CEO of the Wellesley Institute. He has a long CV, but in the interest of time, I'll skip that. Kwame, over to you.
Now, I'm hoping that you can see my screen. Just give me a thumbs up if, yeah, great.
We can.
Thank you. So thank you, Dr. Krug. Thank you, Dr. Yamamoto, Professor Marmot, sorry, and Dr. Valentine for such a comprehensive synthesis of the inequities of COVID and COVID-19 linked to the social determinants of health. Now I'm going to change pace a little bit. And I'm going to talk about some of the work we've done in Canada, which aims to decrease inequities. My name is Kwame Mackenzie. I'm a physician researcher and CEO of Wellesley Institute. And I moved from working in academia alone to working at the interface of research policy and action. And now the Wellesley Institute is an independent, non-partisan, research-based policy think tank which aims to improve health equity through actions on the social determinants of health. We do this in partnership with community, other organisations, and with government. Now, like most of the presenters, we see the pandemic as increasing existing social and health inequities and inequalities. I mean, inequalities like a laceration in our protective skin through which COVID-19 can more easily enter, and healing that laceration is vital to a good public pandemic response for all, as well as our resilience to other challenges going forward. But we also see it as an opportunity. And this is because governments may align. They're focusing on one thing, the pandemic. They're focusing on data, and they're also focusing on evidence. And because communities may also be more receptive, there's a chance to hardwire aspects of health equity in policy and action going forwards. So there are challenges, but there are also opportunities. So start off with Canada. I'm showing Canada because it's not the US of A, that's south of us. And we're in Toronto, and Toronto is 6 million people. It's in Ontario, a province of 14.5 million people, and in Canada, which is 37 million people. And Canada has had, most people would say, a good pandemic response, but it's not been equal. We have some data now, some disaggregated data, but we didn't have it at the start of the pandemic. And we now know it on a national level, echoing some of the things that Nicole presented. Mental health impacts 30% greater for racialized groups and greater for women aged between 18 and 54. At the Ontario level, when we've done area-based analyses, we've been able to show that hospitalizations and death rates are doubled in areas with larger racialized populations. And as the data has eventually come in at Toronto, we've found that the infection rate is 5 times higher for those living in poverty and 6 to 9 times higher for racialized groups. So there's a lot to do. and across Canada, many people have been busy. I'm talking about what Wellesley's done, and we have had a busy pandemic. We've had some success working with stakeholders and other groups. It's not done by ourselves, it's done through our networks in improving some things. One of the things, picking up on what Nicole had said about income support, we had a rapid survey that we brought out straight after the new income support was developed for the pandemic. It's called the Canada Emergency Response Benefit. 540 of our stakeholders replied to our survey within 1 week, and we were able to give clear guidance to the government, which actually they took up, and that helped the equity of the access of these supports to marginalised groups. So they changed the law. We were able, by animating our networks and using the media and other relationships with government, to lean on the government to release $1 billion for homelessness and housing supports between wave 1 and wave 2, trying to get them to do that before wave 2 started. Uninsured people in Ontario are now getting access to free healthcare throughout the pandemic, but it's continued into wave 2 because of the actions of community, but also because of a network called the Network for Uninsured that is housed at the Wellesley. And then in midsummer, we presented to the Standing Committee of COVID at the federal level, calling for equity-based pandemic strategy. We believed that that had fallen on deaf ears, but just a couple of weeks ago, the Public Health Agency of Canada brought out its annual report, echoing almost exactly what we said. We can't say it was down to us, but we're hoping that it was. But I wanted to talk really about sociodemographic data collection because that's something that the other presenters, both Michelle and Vera, are going to talk about, and because it's a place where we have had some traction. But I wanted to stress that it's not the data collection that is most important to us. It's the data collection plus the governance plus the data use. The data use is the most important thing to us. Now, Wellesley has actually had a long history of trying to get all levels of Canadian government to collect sociodemographic data to measure disparities in health. And we've had some successes and some failures, but at the start of the COVID-19 pandemic, sociodemographic data was not being collected in Canada. But in April this year, some things came together. The US and the UK reported disparities for their Black populations in risk of COVID and outcomes from COVID. There was a rise of the Black Lives Matter group after the death of George Floyd, and questions started being asked about why we didn't have those data in Canada. Now, we worked to amplify that, and then we worked with partners and convened a cross-sector group, which included community experts, service providers, policy experts, and academics, and it's called the Black Health Equity Working Group. We then started to push government to act and start collecting data, but more importantly, to act with that data. We set a strategy, produced research syntheses, op-eds, newspapers, radio, TV, spoke to policymakers, bureaucrats at all levels, and exerted considerable pressure. But we're in the middle of a pandemic, and in a pandemic, you have to be useful, otherwise you're a problem. And so we started working with parts of the provincial government to help them craft their strategy. we identified tools for data collection. We produced a model of data governance, and of data use. So we were, on one hand, you're putting pressure on them. On the other hand, you're giving them tools to move forward. But of course, at the same time, you have to continue to exert pressure to make sure something changes. So what happened? Well, in May, Toronto agreed to start collecting sociodemographic data. And by July, they were identifying considerable disparities by income and race. By August, they had started a consultation with communities to say, what can we do to deal with these problems and to decrease the inequities? And by September, they brought their equity action plan to the City Council. And that included things like buying hotel rooms so people could socially distance. It included changing how they're doing testing and tracing, and also access to some of the things like information and community-based animators, very similar to the things that Nicole was suggesting. Now, Ontario is a bit more difficult to crack. Toronto is a centre-right mayor. Ontario is more right-wing. But they were convinced. They actually changed the law in June to allow sociodemographic data collection across all public health units. And that started in June. In August, they set up the Ontario Health Data Platform to give people access to data with equity as a main sort of underlying value. And just a couple of weeks ago, they asked us, and we've sat and had 2 sessions where we co-chaired the provincial group that really has moved forward with the planning, the data analysis, and the data use, and that's co-chaired with the Chief Medical Officer. But we were somewhat blindsided in September by the fact that as part of the throne speech for the new government of Canada, they decided that not just for COVID, but going forward, that there was going to be a plan for sociodemographic data collection. And this one definitely wasn't us. We had talked to government, we had been working with government, we'd suggested it to government, but nobody had actually told us that this was happening, because sometimes these things have a life of their own. I cannot claim that this is directly linked to us, but I think that it is interesting that our centrist government is doing something that's following more right-wing governments who've taken on the idea of data collection, sociodemographic data collection in COVID. So what have we learned?
We're going to have to wrap up.
I'm wrapping up right now.
Great, thanks.
Our governments are more aligned and focused and data sensitive, and they're able to listen in wave 1. There was an opportunity to make progress on equity, being solution focused, having a track record, having good partners to work with, and being non-partisan helps. And all levels of governments are now thinking of doing what Michael has suggested, and not thinking just of equity and health equity and inequities during COVID, but what it means for the recovery and beyond. Thank you very much.
Thanks so much, Kwame. This is very impressive. I wish all city and national governments were as much on the ball as yours, but well done. We continue our tour around the inequity world and go to South Africa, where we're going to hear from Vera Scott. Vera is professor at the School of Public Health at the University of Western Cape.
Thank you. Thank you, Etienne. I work at the University of the Western Cape. I'm an associate professor there, but I'll be sharing some insights that really come from working with primary healthcare service managers on the ground and with public health colleagues across different departments and academic institutions. And I thought today what I would share with you is a little bit of the experience of Khayelitsha, which is a peri-urban community just outside of Cape Town, part of Cape Town in the Western Cape. I'll share with you some data which comes from different dashboards that have been developed by the Western Cape Department of Health, which really committed itself to a data-driven decision-making approach, and I think mounted a fairly formidable response, health system response to the pandemic in the province, and working with local government in Cape Town. I'm just going to share my screen with you. And I'm hoping that you can see the presentation. Great, thank you very much. Okay, I'm just trying to see how to move the slides.
Click on your screen.
Fantastic, thank you. So the first case in South Africa was on the 5th of March, and then spread to the Western Cape. It was in KwaZulu-Natal. COVID came in really through international travel, and so not surprisingly affected the more affluent communities of Cape Town first. But already on the 28th of March, we had the first case in Khayelitsha, which we think was related to workers in the hospitality industry moving from the affluent suburbs to the peri-urban township. South Africa is an upper middle income country, and I think this is really important for us to remember. And the real issue in South Africa in terms of poverty is the inequality that exists. And here we have a graph of the Gini coefficient showing just how high the income inequality is in the country. South Africa is one of the most unequal countries in the world. The top 20% of the population hold 68% of the income, and the bottom 40% of the population hold 7% of the income. We have a very, very high unemployment rate, 28%. And if we use the expanded definition, which includes those people who are unemployed but have stopped actively looking for work because of long-term unemployment and despair, that goes up to 36.8% before COVID. Childhood poverty, 6 out of 10 children experience multi-dimensional poverty. So this is the context in which the COVID pandemic landed. Here we have a map of the municipalities in South Africa, and on the left, what you see there is poverty levels, and the blue shows that the Western Cape, if you look at the bottom left tip of the country, that's the Western Cape, and the blue indicates that this is the wealthier part of the country. But if you look then on the right, the graph on the right, you'll see that the colors change red, and that's really indicating this is the Gini coefficient. So it's also the most unequal parts of the country. And then if we zone in on the socioeconomic status of Khayelitsha, as I said, it's a peri-urban community. 98% of the community is Black African. You will see that the household income that is below the poverty line is extremely high, over 70%. 55% of households live in informal dwellings. And importantly, in terms of COVID, 38% of households not having access to piped water, either in the dwelling or in their yard. So multi-dimensions of poverty in an informal community. And so I'd like to look at some of the challenges that health services faced in their response to COVID in this particular setting. You will see that on this graph we have the COVID cases in the Cape Metropole, really reaching their peak around May, but in Khayelitsha, a slightly earlier peak, which I think is also quite interesting, and we'll come back to that. The first dimension of how social determinants have impacted in Khayelitsha is really that of differentiated exposure. As I said, this is a country where there's huge inequality, and I think what's really interesting is that we're looking now at a global pandemic. It's affected rich and poor countries alike. It's affecting the rich and the poor within countries, but to a different extent and with a different impact. In South Africa, the first response, an early response in March, was a national lockdown, a hard lockdown for 6 weeks, where only essential workers were allowed to go to work, and the rest of the population were only allowed to leave home to buy groceries at the nearest store. And this really had an incredible impact on the informal economy, which is the lifeblood of a township such as Khayelitsha. The photograph that you see on the right is a sobering one. This is taken in May, and it's of the people waiting to receive the social grants, child support grants, and old age grants. And really, what you see in a situation which was supposed to be a lockdown situation to enforce social distancing, what you see is this incredible overcrowding as people come together, really in desperation. And this is hunger in the streets. People who are desperate to receive some cash in order to be able to provide for their families. And the picture on the left there shows people in a taxi during the hard lockdown. There was no public transport. This made it really difficult to get health staff to work. And again, in a divided society, we had doctors able to come to work in their own transport, but the majority of nursing staff and the support staff within services being exposed to COVID on their way into work. And many of the outbreaks that we had in the health facilities was actually related to staff traveling together. So as much as this is a pandemic that affected everybody, there was differential exposure in a community such as Khayelitsha. There was an amazing public health response, as I said at the beginning, and here we have the 5 golden rules of good hygiene. And I just want to pause for a moment and ask you to consider how one actually applies these rules. So number 1, wash your hands often for at least 20 seconds with soap and water. And what does that mean when actually you don't have water in your house or in your yard? And when there's a lockdown situation where you are not supposed to be going out. And of course, people did have to go out and use the communal taps. And those became gathering points and places of potential transmission of COVID in townships. The environmental health teams were out on the ground and distributing 2-liter plastic Coke bottles, cool drink bottles, which have been modified in order to to make a sort of a squeezy water dispenser. The other advice, number 5 there, stay home if unwell. And this was so important in terms of the quarantine and isolation procedures. And yet again, if you live in an informal dwelling, 2 bedrooms, yes, you're going to stay at home, but how do you stay apart from the rest of the family in a situation like that? So we had to look at isolation and quarantine facilities in various government facilities across the Cape, but this was a very big issue for the health services in terms of the response. The second aspect where I think social determinants of health equity become really important is that of differentiated vulnerability. And the graph here shows the premature mortality in Cape Town from a burden of disease study done by the Western Cape Department of Health. And you can see how HIV, AIDS and TB accounts for the vast 18% of the premature mortality measured in years of life lost. Also important to note non-communicable diseases and diabetes and how much they feature here as well. As we realized that COVID was approaching and was beginning to move into the townships, we were very, very scared about the impact that it was going to have in poorer communities, and particularly in a community such as Khayelitsha, which has one of the highest rates of HIV in the country, and with it a very high TB incidence. And so the concern was how it was going to affect the morbidity and mortality in this group of people. But amazingly, it did not have as much of an effect as we feared. And this is work that was published. It's been published now in peer-reviewed journals by Mary-Ann Davies and colleagues around the drivers of mortality in Cape Town. And if we look at the adjusted hazard ratios, what we found is that HIV has a ratio of around 2, whereas uncontrolled diabetes has a ratio of 10. And so what really drove the mortality in Cape Town was not HIV as we feared, but diabetes. And I think this is really, really important for us to actually understand, because the next question is then, well, what are the social determinants of diabetes? And
you're going to have to slowly wrap up. I'm sorry, Vera.
Okay, thank you. I don't think I could speak from the University of the Western Cape without mentioning the late David Sanders and the work that he's done on social determinants. And this particular analysis comes from some work that Nikki Shea and I did with David a couple of years ago, where we looked at the particular social determinants of obesity and diabetes. And I think what this demonstrates is that if we are going to be able to mount a full response to the social determinants of COVID, we actually have to begin looking at the structural determinants. And it takes us into the world of trade, it takes us into the world of food systems and global economic systems as an area for action in terms of addressing the inequities. I need to curtail the presentation, so I'll just show this slide around differentiated access to care. You will know that South Africa has a 2-tiered health system. We have an extremely strong private care system. 50% of health expenditure is in the private system, but 85% of the population rely on the public as health service. And so that introduces another dimension of inequity. And you can see that the number of tests done in the private sector are at least 50% of the tests done, whereas it's only servicing 15% of the population. And in terms of hospital admissions, we see a similar kind of a pattern, slightly longer stays for private patients and a far greater rate of hospitalization. So different criteria for admission in the public and private sector, but a good quality public sector. So the mortality rate in private and public being similar. And then the last slide then is around the differentiated impact, and this slide speaks to the job losses, 2.2 million jobs lost in South Africa. But just to note where those jobs have been lost, that the poorest 50% have experienced the most job losses, that those who do manual labor have experienced the greatest job losses, and of course women. And so I think what we're seeing here is the gendered nature of the impact. This is contributing to poverty, and we know poverty in South Africa is racialized, and so we will see with this increased racial inequity through and having health impacts more broadly through poverty, through hunger, and greater susceptibility to disease, and greater barriers to actually accessing basic services and health services. Thank you.
Thanks so much, Vera. This is fascinating, and it's interesting to see how the picture you describe in South Africa confirms many of the global facts we have found in many other countries. I think that one picture of people standing outside looking for food is incredibly telling. So we're moving quickly now to our last speaker, talking about surveillance and data in France. Michelle Kelly-Irving, who is a researcher at INSERM. Michelle.
Yes, thank you very much. Okay, so a brief overview of the health inequalities situation from a perspective in France. As many countries, one of the things we suffer from in France is we do lack good quality surveillance data, which would allow us to quickly examine the social distribution of a new emerging disease like COVID-19. Now, we're not alone in that problem, but it is one that slows us down when we're trying to get to grips with the health inequalities question. The way things emerged in France was during the first spring lockdown, where we had a hard lockdown. The statistical office in France reported a disproportionately high mortality rate in the poorest department of mainland France called Seine-Saint-Denis. This became headline news, and suddenly everyone started to become concerned about the health inequality situation, when of course when you work in this field we were fairly certain that this was all going to pan out as unfortunately we expected, but we had very little to go on. So with the lack of data, of surveillance data, a number of ad hoc COVID studies were set up, and these have become vital sources of information, and we're actually only just getting those results now. So because we have to set these studies up specifically for this, they take a lot longer, and we get the results, you know, with a lag time that's considerable. So one of the major studies that was set up during the lockdown and is run by colleagues in Paris, and Nathalie Bajos and colleagues. It was a representative sample funded by the government on over 130,000 French residents. And here I can report some results that came out just a couple of weeks ago on SARS seroprevalence, so a seroprevalence study during the first wave on 12,000 people. So we see that 4.5% were COVID positive based on this sample, this representative sample of the French population. And when we break that down into different subgroups of the population, what you see is that you have a higher rate of infection among women. Healthcare workers, much higher, 11%. And when we look at people born outside of Europe, people living in overcrowded housing, and also people living in densely populated areas of the country, that seroprevalence is also at a higher rate of 9%. Now, another study that was set up during the lockdown, we were able to ask some questions to people in a representative sample of the French population during the lockdown period about their social conditions. And we know that just on the left here, 21% of people in this sample reported never or rarely being able to isolate an unwell person, a sick person, in a separate home, a room in their home during this period. So of course that's one of the recommended things to do, is to be able to isolate a sick person. But that increased to 30% when you look at a more socially disadvantaged group of the population. So when people were from a group with low educational qualifications, well, 30% of them were not able to isolate somebody in their home. On the right-hand side here, we have some hints about what we could call health literacy. So we know from this sample that 11% of people with no educational qualifications report struggling to understand and needing help to understand medical prescriptions and medical information, as compared to 5% of participants in the other education categories. So again, this indicates to us that there is a gap in terms of how our communication is functioning and how easily people are going to be able to follow instructions and understand what's happening in terms of social and socioeconomic factors. Now, there's something I haven't really mentioned, and it's the kind of elephant in the room with regards to what's going on in health inequalities in France. It's something that's a taboo subject, really, and that's the question of racism and ethnic inequalities that several of the speakers have already alluded to. Now, this picture here is pictures from that poorest department of France, where I mentioned earlier the highest mortality rate, excess mortality rate occurred. That's Seine-Saint-Denis. Now, it's a department that's well known for having higher rates of people living there coming from recent immigration backgrounds. So high proportions of people who are potentially minoritized and racialized populations. But of course, we can't measure that in France. So I'd like to mention that there, this quote from Nancy Krieger here, that there's nothing distal about structural discrimination. It is intimately lived and embodied day in and day out, as she would say. But we do have some hints about this type of inequality, and that no doubt it's probably related strongly to poverty and socioeconomic circumstances. These data here come from the INSEE, which is the French National Statistical Office, and they talk to the excess mortality rate occurring again during this lockdown period. And this time the variable of interest is, where were you born? Were you born in France, or were you born in another place? So it's a sort of migration variable, but it gives us some indication of potential discriminations and disparities among racialized populations. So the excess mortality was 22% if you were born in France and you lived, during the lockdown. That rate rises up to 55% if you're born in North Africa, to 90% excess mortality if you're born in Asia, and to a whopping 114% if you're born in sub-Saharan Africa. So it does give us some indication of something that's going on in terms of these inequalities on the French territory during that time. Now, a bit more information comes again from the EPICOV study. This time we're looking here at some results, which is regression models. And it's showing us the odds of having tested positive for the virus for people born outside of Europe compared to the French-born people And here we have unadjusted and adjusted odds. So 2.4 odds ratio, you're more likely in that case to have the virus if you were born outside of Europe. And once you adjust for socioeconomic factors, housing and other factors like that, that odds ratio drops down, and it loses its statistical significance. So there's some indication from these results, again, coming from these precious ad hoc studies that were set up, that these are probably poverty and socioeconomically driven structural problems. Now, just to sum up, as I mentioned, the real missing link that to allow us to ascertain what's happening in social inequalities terms in COVID and other crises is the lack of surveillance data. So this is really me advocating for the fact that data governance needs to transform for us to really be able to follow a health inequality situation, and we need to unlock the barriers to that. In France, we have actually very rich social data, and that's that you see there on the left, from the census, from work, retirement, education sources. And on the right-hand side, we have good quality health data from various sources, from the health insurance, from hospitals, from general medicine sources as well. And if we were able to actually perform ethically safe linkages and interoperable and identifiers, etc., then we would actually be able to supervise and understand what's happening with health inequalities and potentially act earlier and maybe inform our ad hoc studies a bit more specifically. So that's what I would advocate for this time. Thank you very much, and thank you to my colleagues and the funders that we have for this study.
Thanks so much, Michelle. Very strong numbers and strong data that again tells the story very clearly. Unfortunately, we had hoped to have some discussion, but we are running out of time. So, but this is just a first, I think, in a series. And if there was a need, I don't think there was, but if there was a need for us to be more convinced even about the importance of this topic and to act, this webinar certainly has helped. So thanks to all who turned up. We want to continue the dialogue. We want to see this as just a beginning. We want to build also on that data to make sure that all governments in all countries and all cities are well aware of this situation. The pandemic is unfortunately probably going to be there still for a while, and we need to learn lessons for this pandemic, but also make the case for, as Michael and others have said, for acting on these issues for the years to come in our societies. So I want to thank again Naoko, Michael, Nicole, Kwame, Vera, and Michelle for the great presentations and discussions. Thanks you all for coming, and we'll continue this. So if you have suggestions for topics to address, we're already planning also to talk about the rise in violence in one of our upcoming webinars. Also issues around housing. But if you have topics or suggestions, please feel free to write to Nicole, and we'll be in touch. This will be posted and made available to others to follow, so please also make others aware of the availability of this webinar to watch in the future. Thank you very much to all. Stay safe.
Thank you, Etienne.
Bye.
Thanks, Etienne. Thank you, panelists.
Thanks very much, Nicole.
Thank you, Naoko.
Thanks.
Thanks to all. Great presentations.
All right.
Bye-bye.
Good sharing.
Thank you all very much. Thanks, Nicole.
Okay, thank you. We'll be in touch with the links for the recordings, and also we'll PDF the presentations.
Okay, thanks. So then, Nicole, if I can then just send you
Sure.
the updated. It actually just has a more complete reference list,
Sure.
which I think will be great to put
Sure.
out there. Okay, thank you so much.
Thank you very much, all.
Thank you, everyone who
Bye-bye.
came. Please write to
Thank
us with suggestions, or we'll have sorry, we didn't have time to address more questions.
Okay.
Yeah.
Thanks very much. Bye-bye.
Okay, bye-bye.